This session is being recorded. And a kind request, please put your cell phones and computers on mute. And any questions to the speakers, please enter them through the chat box. Our moderator will be monitoring these questions, and they will be presented to the speakers at the end of the session. So please be patient. And if at all the meeting drops, please go back to the original link in your email and rejoin this meeting. Like mentioned before, the session is being recorded. And if we are unable to get to any of your questions, you could send in your questions to Dr. Deanna Aronoff at acgov.org. Here are some resources that's available on our website for regular updates, and you can also sign up for our Alameda County Health Alerts. And a special thanks to Dr. Huang Lei for her contribution in helping us plan this webinar. And special thanks to our local dental societies, the Alameda County Dental Society, Southern Alameda County Dental Society, and Berkeley Dental Society for partnering with us to help us bring this webinars to you. Now, without further delay, I'll turn this presentation over to Dr. Deanna.
Good evening. Tonight, we're going to start with guidance for dental healthcare providers responding to cases of COVID-19 in their office. Next slide, please. Everybody has a plan is the topic for tonight, and this is a famous Mike Tyson quote about everybody has a plan till they get punched in the face, which is kind of how we feel with COVID-19 and wildfires in California right now. Next slide. Thank you. How does SARS-CoV-1 compare to SARS-CoV-2? So SARS-CoV-2 is more infectious. In 8 months, SARS-CoV-1 infected 8,100 people. Within 5 months, SARS-CoV-2 has infected 2.6 million people. Of these, about 40 to 45% are asymptomatic carriers. SARS-CoV-2 is very contagious, partly because one is infectious 2 days before having symptoms or being asymptomatic by going out in public. This is another example of why people need to wear masks. Next slide. By the end of this portion of the webinar, participants will be able to identify what to do if an employee is symptomatic for COVID-19, what to do if an employee is diagnosed with COVID-19, what to do if a patient is positive for COVID-19 and has visited the office, and what other precautions should a dental office take when a patient or employee with COVID-19 is identified. Next slide. So if an employee is symptomatic for COVID-19, first document the date the employee reports the symptoms, and then send the employee home if they are at work. So these symptoms include fever of 100 degrees or more, chills, cough, shortness of breath, difficulty breathing, fatigue, muscle aches, headache, new loss of taste or smell, sore throat, congestion or runny nose, nausea or vomiting or diarrhea. The employee may return to work when they meet the criteria laid out in the CDC criteria for return to work for healthcare personnel with SARS-CoV-2 infection. The criteria to return to work and release from isolation include 10 days have passed since symptoms first appeared, 24 hours have passed since fever without use of fever-reducing medications, and symptoms such as cough and shortness of breath have improved. So symptoms like loss of taste and loss of smell take longer than 10 days off to recover, so we look for that. Next slide, please. We would suggest that your employee have a medical evaluation. They should contact their primary care provider to see about getting tested. If the employee is tested and willing to share, ask that they communicate the date of the test result, the source of the specimen, what type of test was used, and document all this in your records. Now, if your employee is actually diagnosed with COVID-19, next slide. First, you need to inform the other dental healthcare personnel that someone in the office was diagnosed with COVID-19, but do not disclose who this person is unless the employee with COVID-19 has agreed to be identified. So today we have a revised definition of close contact for Alameda County, but don't panic. It's really basically the same as the old one for healthcare workers. So close contacts this new definition does not include healthcare workers as long as they are using the correct infection control precautions, including all recommended personal protective equipment. The person that might be affected by the close contact could perhaps be a receptionist in your office, for example, who isn't wearing an N95 and doesn't have on the full face shield. So this is a little bit different in that they are talking about brief interactions where there's unprotected direct contact. So like if someone were to sneeze on your receptionist, and cumulative exposures that add up to 15 minutes within a day may also be considered close contact depending on the intensity of exposure. So multiple interactions in a confined space with a symptomatic COVID-19 infected person. Like I said, it won't affect the healthcare professionals. The one you need to watch out for would be probably your receptionist. Next slide, please. So first you need to assess the contacts during the 48 hours before the COVID positive employee had symptoms or when they had the test taken if they had no symptoms. So for our purposes, the close contact is defined as being within 6 feet or closer for 15 minutes. This includes staff as well as patients. So you want to ask the employee with COVID-19 to identify close contacts among staff and patients during that 48-hour time frame. And then if the employee is willing to be identified, ask the other employees to identify their close contacts during that same time frame. Then you also need to find out if they actually were wearing the PPE and that it was worn appropriately. And here's the kicker. A non-fit tested N95 respirator is considered as no protection and is considered a close contact. And we were on the phone yesterday with subject matter experts from the CDC, and that's honest, and that's what they go by. That's the statement. Next slide. So you want to ask the close contact to self-monitor symptoms. You want to ask any dental health professional who are close contacts to self-monitor for fever or symptoms consistent with COVID-19 for at least 14 days after the exposure. They have the option to get a COVID-19 testing. The best time to test is 4 to 10 days after the contact to have enough viral load in the nasal pharynx to be detected by the COVID-19 test. And even if they have a negative COVID-19 test, they still have to quarantine for 10 days if they had a close contact. Even if they test on day 10, it's a negative test, they still have to quarantine for the entire 14-day period. Next slide. You need to send home any dental healthcare personnel who had close contact and at least one of the following criteria are met. The dental healthcare professional was not wearing a fit tested respirator, face mask, and they were not wearing proper eye protection. Glasses are not proper eye protection. It needs to be a full face shield or goggles. Next slide. So this is a hard part, contacting potentially exposed patients. If the dental healthcare personnel were not N95 respirator fit tested, then the incident is considered a close contact and patients will have to be notified. So you can call the patient, identify yourself in your office, calmly state there's a person in your office that tested positive for COVID-19, while the patient was there. You might use a phrase like, we're concerned for your health and we want to be upfront about this possible exposure. Not an easy thing to do. Then you get to contact us next. We have a new reporting form and there should be a hyperlink on this. These slides will be available after the presentation, probably by tomorrow. So you want to use the workplace case and contact reporting form. And there's also a contact email address on the same slide that you can access after the presentation. Next slide. You also have to contact your workman's comp representative because the bill says that California employees who work at a job site outside of their home who test positive within 14 days of working are presumed to have contracted it at work, even though maybe they probably didn't, but they still, this is how the law reads, so you have to contact workman's comp. Next slide. Then you get to contact Cal OSHA. So if you have employees that have taken days away from work, then you have to contact your local Cal OSHA office and report that. Next slide, please. And then these are the different forms that you can use to report. Next slide. Now, if your employee is an inpatient in a hospital, it could just be one evening there. But if they are an inpatient and you find out within 8 hours, you have to notify Cal OSHA of the time that you were notified of your employee's hospitalization. Next slide. So when you get a different kind of a respirator, you're still supposed to get it fit tested. The annual fit test, let's say you were lucky enough to get all the same N95s, you don't have to do an annual testing, but you do have to do an initial fit testing specific to that N95 respirator. Next slide. So if I don't provide N95 respirators to my staff and I don't provide fit testing, what could possibly go wrong? Well, Cal OSHA did close a dental clinic at San Quentin, citing practices that have contributed to the spread of SARS-CoV-2, such as failure to provide air purifying respirators to dental staff. And actually, the dental staff turned in the administration in this case. Next slide. The next one, there was a Massachusetts dental practice who failed in delivering the N95s, and they were cited almost $10,000. Next slide. And finally, we have our friends, the lawyers, who also are looking for a little bit of extra money. And, you know, you could be setting yourself up for a civil lawsuit for unsafe working practices. Next slide. So if a patient tests positive, next slide. Document the date, ask the patient when they notice the symptoms, find out when they were tested. Again, you assess their close contacts. Next slide. Any dental health care professional who's a close contact should again self-monitor. We do have free testing sites within Alameda County, and also they can contact their primary care provider for testing. And some of the local CVS and Walgreens also offer testings too. Next slide. And if any of the healthcare professionals are not feeling well, they need to go home. They need to quarantine for 14 days if they've had close contact with a COVID-19 positive patients. And at least when the following criteria met, they were not wearing a respirator. And if it's not fit tested, then it's considered like you're not wearing one. Did not have proper eye protection, and that's the goggles and the full face shield. And also if there was an aerosol generating procedure, an appropriate PPE was not worn. Next slide. This kind of a mask is not considered the way it is right now. You can see that the shield is too short for the mask, and with that exhalation valve, that should be covered. If you can cover that with a surgical mask that does not affect the fit of it, then you might be able to get away with it, but generally we do not recommend these. Next slide. So precautions upon identifying a positive case. Next slide. You have to perform an environmental cleaning, disinfection of all high-touch surfaces, and refer to the CDC's infection control guidance for more information about this. Next slide. After an employee or patient diagnosed with COVID-19, all staff should continue to monitor for symptoms and make sure not to come to work if they're feeling sick. Next slide. And then where do most of the dental office outbreaks occur? They occur in the break room. So they shouldn't congregate in the break room. You should stagger breaks. Don't share food or utensils. Employees may want to eat outdoors with 6 feet social distance or in their cars by themselves. Next slide. So if someone is identified as a close contact, we do suggest that, you know, they are a high priority for testing. They really should get tested if possible. And a COVID-19 test is most likely to be positive between 4 and 10 days after the exposure. Next slide. This is a really good app. You can put it on your smartphone. It's a CDC Dental Check app, and you can make a checklist, but it also will download all the pertinent, most relevant information from all the alphabet branches of the government. Next slide. This is also a good flow chart. It's just a beginning. Every case is different, but this gives you a good start. That's from your CDA. Next slide. Okay, so life imitates science fiction. Hope is on the horizon. Next slide. And Scotty. Warp speed vaccines. Next slide. And hopefully these will work by next summer, hopefully, and we will be in better shape than we are right now. And next slide. And here are some resources which will be posted. Next slide. And then thank you very much. And I'm going to turn it over to my friend, Dr. Gerling, and he will speak on pre-procedural testing. Thank you so much.
Thank you, Dr. Aronoff. That was a very interesting and informative presentation. I actually learned quite a bit, so I appreciate it. Next slide. Next slide, please. So by the end of this section of the presentation, you should be able to differentiate between the different types of available COVID-19 tests. You'll have some information about how to screen patients appropriately for COVID-19 before their dental office visits. You can determine the appropriate actions based upon the results of screening and use SARS-CoV-2 testing to guide timing of non-urgent dental procedures, especially if an aerosol generating procedure is anticipated. Next slide. So we're going to talk for a moment about the various types of COVID-19 technologies. I think you're going to be treated to the sound of my beagle howling in a moment. I apologize for that. There are two different categories of COVID-19 tests. The first are the diagnostic tests, and the second are the serology tests or serologic tests. The diagnostic tests, which actually detect active infection, include molecular tests, which are known as nucleic acid amplification tests, or affectionately referred to as NATs, and then antigen tests. So the molecular or NAT tests and the antigen tests can detect active infection, whereas a serology test does not detect active infection. It actually detects past infection and really has no role whatsoever in screening patients in a dental office. Next slide. So the molecular diagnostic tests are the gold standard for diagnosing SARS-CoV-2 infections. They detect viral genetic material, and when they are performed in a moderate or high complexity clinical laboratory, these tests are very sensitive and specific. Because of the high sensitivity and specificity, these tests are generally preferred in clinical practice when the goal is diagnostic certainty. The appropriate specimen type varies with the testing platform. And it's important to understand that these tests may be sensitive enough to detect viral shedding after a person has actually recovered from infection. So that is a little bit of a negative on the side of these tests. Next slide. Okay, so the NATs include the reverse transcription real-time PCR or RT-PCR. These can be performed in a moderate to high complexity laboratory, but there is one point of care PCR, which is known as the Cepheid Gene Expert Express, and its performance really is just as good as the test performed in the moderate to high complexity laboratories. There's a different type of NAT, which is not a PCR. It's an isothermal NAT that you probably have heard of. It's called the Abbott ID Now. Its sensitivity is a little bit less than the PCR. And there's another type of NAT called a transcription-mediated amplification test. This is run on the Hologic Panther system in a moderate to high complex laboratory, and it's highly sensitive and specific. Next slide. You're going to hear more and more in the next few days to weeks about antigen testing because this is becoming rapidly more available. These tests do not detect nucleic acid. Instead, they're detecting proteins in the nucleocapsid protein coat of the virus. The primary advantages of the antigen tests are that they are low cost, they're highly portable, and they're performed at the point of care, and they have a rapid turnaround time, some yielding results within 15 minutes. The problem with these tests, from your perspective, thinking about your dental patients, is that if you have screened patients for symptoms and for exposures, they are by definition asymptomatic patients that are at relatively low risk for actually having COVID-19. And the antigen tests are only FDA authorized for use in symptomatic patients within the first few days of illness. So a negative result is presumptive and has to be confirmed with a non-point of care NAT. And that is really going to limit the utility of these tests for screening your patients in dental practice. However, I shall mention that our testing paradigm is changing, and what I tell you today might change next week, but that's our current take on these antigen tests. Next slide. Again, as I mentioned, the antibody tests, although some are very specific serological assays, really have no role in dental practice. You cannot count on a positive serology as evidence for immunity, and you can't make any clinical decisions about your patients or your staff based on serologies at this time. Next slide. So now we're going to talk a little bit about pre-procedural testing. So as you all know, the urgent medical and dental procedures have not been restricted during the pandemic. We've encouraged people to seek those urgent procedures in both inpatient and outpatient settings throughout the pandemic. On the 13th of May, the Alameda County Public Health Department health officer released a health advisory encouraging that medical and dental providers should gradually resume non-urgent clinical services with several important caveats. The health advisory is available for your review at the link noted by the blue words health advisory on the slide. But the main points I want you to take away are that if non-urgent clinical services are resumed, this health advisory strongly recommends the use of appropriate PPE, the avoidance of aerosol generating procedures unless they are absolutely necessary, and it recommends the use of airborne infection isolation rooms when patients with COVID-19 require emergency dental services. So please bear those in mind as we're moving forward. Next slide. Now, in consideration of the risk of aerosolization of viral particles during procedures, back in April, the Anesthesia Patient Safety Foundation and the American Society of Anesthesiologists tried to address concerns that were expressed by medical providers about whether and when they should test patients for COVID-19 prior to performing non-urgent procedures, including surgeries. There was a guidance document developed which essentially said that facilities and providers should implement patient screening and testing policies which provided useful preoperative and pre-procedural information about the patient's COVID-19 status. Test results should be factored into determinations about the timing of elective and non-urgent procedures in order to reduce the exposure risk to staff and other patients, as well as to enhance patient safety, because the safety of performing invasive procedures in patients that have COVID-19 is really not fully understood. Okay, next slide, please. We're going to look just briefly at Alameda County's COVID-19 data. This is a data snapshot from the Alameda County Public Health Department's COVID-19 dashboard, which is available for your review on our website. This is a snapshot from September 22nd, and you can see that overall at that moment, the county had confirmed more than 20,000 cases, as well as 374 deaths due to COVID-19. This dashboard also analyzes the data so that you can see cumulative cases by age group, gender, and race ethnicity, and you can see data for individual cities as well. Next slide. This slide, I would just want to draw your attention to those numbers, 4.8%, which is in the upper left-hand corner. There are four little boxes, and it's the box at the lower right. That is the current test positivity rate, meaning that of all the patients that present for testing, whether they're symptomatic or asymptomatic, when they go in for testing right now, 4.8% of those tests are positive. Next slide. This slide shows you the monitoring metrics that the state is using in its blueprint for economic recovery. Now, within that blueprint, counties are assigned a tier based on two specific metrics that are described in the left-hand column. The first is the rate per 100,000 population, which is averaged over 7 days, and the second is the testing positivity rate. Now, as of Monday, we were in the purple tier, and on Tuesday, we entered the red tier. We have a 4.8 test positivity rate, as I said, and a current case rate of 3.5 per 100,000. We're doing really very well in terms of controlling this epidemic. Next slide. We've already talked a little bit. I need to kind of move forward quickly in order to make room for Dr. Shea's presentation, but just to briefly emphasize what Dr. Aronoff has already said, that the duration of exposure, the physical proximity between patient and provider, and the use of aerosol generating procedures in the dental office really increase the potential for transmission if appropriate PPE is not being utilized and other administrative and environmental protections are not being utilized. The pre-symptomatic infections and the asymptomatic infections really are complicating the management because screening alone for symptoms is not going to exclude all of the patients with COVID-19 from your office. And currently, a recent review of 2 data sets in California show that 22 to 38% of patients testing positive had no symptoms at the time they're tested. Skip ahead 2 slides. Next slide, please. We're going to skip that definition of close contact and move down to, I believe it's slide 67. Thank you. So while there is active transmission of SARS-CoV-2 in Alameda County, the health department is recommending that dental providers implement policies and strategies that include screening of all patients for symptoms of COVID-19, as well as exposure to patients with exposure to contacts with COVID-19 prior to scheduling them for any kind of an appointment. And then we want you to consider selective pre-procedural testing of patients that are undergoing non-emergent dental procedures that may involve intubation or the generation of biological aerosols. Next slide. We've kind of been over this, so we're going to skip ahead to slide 69, which essentially recommends that if you're going to do pre-procedural testing, if you elect to do that, we would recommend that you use a NAT. Next slide. You need to confirm the negative test result, and here are some various methods that you can use to do that. And next slide. Even if you have a negative test, you still need to exercise all of the appropriate precautions because a negative test does not definitively rule out infection. Next slide. Okay, you can skip ahead to slide 73. Deanna has been over this, but essentially if a patient tests positive for SARS-CoV-2, their elective procedures should be delayed until they are no longer infectious, they've demonstrated recovery from COVID-19, and they meet the CDC criteria for release from isolation. Next slide. So in the dental setting, which test should you use? The ideal test for a dental setting would be a diagnostic test, not a serology, with a high negative predictive value. That means that if the test is negative, you can be very much assured the patient does not have COVID-19, and it should have a rapid turnaround time. A same-day test would be best. 24 to 48 hours is pretty good. An RT-PCR test performed in the lab with 24 to 48-hour turnaround time would be a good choice. The Cephia Gene Expert Express, which is available on the same day, is a good choice. The Abbott ID now has a lower sensitivity, but that might be a good choice as well. And in the future, as we mentioned, antigen testing could be considered, but right now it is really not authorized for use in testing asymptomatic patients for clinical reasons. Last slide provides you with links to the laboratory testing guidance for clinicians that was just posted on our website today, and our interim guidance for reopening for non-urgent dental procedures, and actually the second of those 3 references is the guidance on testing for SARS-CoV-2 before non-urgent procedures. Thank you for your attention, and I'll turn this over to Dr. Shea.
Thanks so much, Louis, for the great background into my section, which is considerations for establishing COVID-19 testing within your practice. Next slide. After this part of the presentation, you should be able to identify COVID-19 point of care testing options, understand COVID-19 regulatory and reporting requirements, and be able to access different COVID-19 laboratory testing resources. Next slide. So if you are considering doing testing within your practice, such as the Cepheid or one of the Abbott ID Now tests, or even the antigen tests, know that these are considered laboratory tests and they are regulated by CMS, and especially under this CLIA regulation. And Congress passed the Clinical Laboratory Improvement Amendment, which is CLIA, in 1988 to establish quality standards for laboratory testing to ensure the accuracy, reliability, and timeliness of patient test results. CLIA regulations are based on the complexity of the test method, and so there are 4 different types: waived, provider-performed microscopy procedures, moderate complexity, and high complexity. Within the dental practice, you will likely be trying to register for a waived certificate, highlighted in red here. Next slide, please. So, as Dr. Gerling has indicated, there are two different types of tests which will be utilized, which can be utilized in your practice, which are NAT tests, which is kind of the Abbott ID Now, and the Cepheid Gene Expert, which are some point of care tests, in addition to antigen tests. Both will require that you obtain a CLIA certificate of waiver. And as Dr. Gerling mentioned, nucleic acid tests detect viruses' genetic material, whereas antigen tests looks for fragments of viral protein. While antigen tests are rapid, they have a lower sensitivity in comparison to the nucleic acid tests. For example, for the Abbott ID Now, published references indicate that it potentially has a 75% sensitivity, whereas it's 100% specificity. Similar with the Gene Expert or the Cepheid, there is high sensitivity or percent positive agreement, and they found it upon the FDA EUA website a 97.8% sensitivity and a 95.6% specificity. For the antigen tests, if you can go to the next slide. With the antigen test, you can see here that there are 4 that are available, and the test performance is indicated in the 5th column over. And there is varying sensitivities, and it's not necessarily comparable to what is indicated for the real-time PCR tests. And so it's just to kind of reiterate, the antigen tests are slightly less sensitive, but they are very rapid, which is a really nice selling point. Here are the 4 different types that are available on the market right now and that are FDA EUA approved. As you can see here, kind of different requirements for the specimen types, as well as time to result after you have loaded the specimen on the instrument. If you want more information, there's a link provided further down that will guide you to the different FDA EUA tests. In order to be able to be authorized to kind of run these tests, you definitely need to have a certificate of waiver. In addition, there'll be training webinars to ensure that you're conducting the tests properly. You will have to follow state guidance as to whether or not your practice is able to obtain these tests and whether or not your practice is able to obtain a certificate of waiver. Next slide, please. I know that a lot of information have also been released about saliva tests, and currently there are no saliva point of care tests, meaning there are no tests that you can run in your clinic that you can just use saliva. You can collect saliva in a specimen collection tube, but that then has to be sent to a laboratory for testing. Here are the different facilities that are offering saliva testing. Some of them are like the Yale School of Public Health, where they may not accept your specimen, but then they are offering it to potentially students from Yale School of Public Health. And as you know, they've been teaming up with the NBA for some testing as well. But there are other companies that will provide that testing if you send the specimen in. This database is a database created to help people sort out all the different tests on the FDA EUA website. It provides performance characteristics. It allows you to see what specimen types are being collected. It also allows you to see like what type of laboratory you need to be in order to run that specific test. So it is a very handy and helpful website that you can refer to. Next slide. So as being at a facility that will run the laboratory tests, there are regulatory requirements and reporting requirements as well. As I mentioned earlier, in order to run these point of care tests, you have to have a CLIA certificate of waiver. And so here is a link to the website that will allow you to apply for the application. And according to the Laboratory Field Services at the California Department of Public Health, which issues the certificates, if you have a complete application, it can be processed within 10 days. In addition, because you are running laboratory tests within your practice, you will also be required to report results of any tests to the California Department of Public Health CalReady system, which basically logs all the testing that occurs within the state. so that we have good data as to the positivity rates statewide. And so here are just 2 forms to set up an account with CalReady, in addition to some quick start guides. In addition to reporting all the test results to the California Department of Public Health, positive results then need to be sent to the Alameda County Public Health Department, or where your practice resides, and a CMR form needs to be completed for all positive COVID-19 tests. Great, next slide. So this is just a list of resources available that are available to you as a resident of Alameda County. And there is Alameda County free testing sites. There's also statewide sponsored free testing sites. The third link is a link to all the different labs kind of approved or pre-approved or vetted by the California Department of Public Health Testing Task Force to contract for testing if you decide that you would prefer to send your specimens to a laboratory for testing rather than setting up testing within your own clinic. The fourth link is just a link to that testing comparison database that I showed you earlier. And the last 2 are just more information about point of care antigen testing and guidance on when is the best time to use the rapid antigen tests, as well as use in asymptomatic individuals. Next slide. Great, thank you. And then last slide, please. And we're going to open up to questions.
Okay, so this is Hunlei, and I hope you can hear me. We do have some questions coming in. The first question is, if we are part of a health center which already has a CLIA waiver, do we still need to have a separate CLIA certificate with testing in dental?
No, so if you work within the center and you are considered part of that facility, then the CLIA certificate of waiver should apply to the dental component as well. And so you should be able to run those tests after proper training.
Okay, great, thank you. So we have another question. Do you have any data of transmission in dental setting from dental staff and providers to patients and vice versa?
I can take that if you want. So we really, it seems to be the mode of transmission seems to be mostly among employees in the break room, as I showed in the slide so far. I think people have been very careful about their PPEs, and that's really makes a difference, especially if they're fit tested. But I think as we continue on with this COVID-19, we could start to see some of that. But right now, it's mostly been employee to employee, like in the break room or in some setting. Maybe they drive to work together or whatever, but not yet.
Okay.
May I just add to that?
Yes.
Yes, please.
So I agree that that's all we know, but it's important for listeners to understand that we actually do not have very good data about dental associated cases. We went to our outbreak investigation team to ask this question on your behalf because we knew you would ask it. And what we were told is what Dr. Aronoff just said, that they were aware in Alameda County of 1 outbreak among staff. They were not aware that the disease had been transmitted to the patients or vice versa. And we checked in with the CDC and asked the same question. And what they said is that as far as they know, no one is actually gathering that data. So the fact that we can't provide you with that data about transmission, it's great. Hopefully it's not happening for all the reasons that Dr. Aronoff mentioned, but there is that potential. So we want you to continue exercising all the precautions that you're exercising.
Okay, thank you so much, Dr. Aronoff and Dr. Gerling. So we have another question, then this is for Dr. Gerling. So just want to confirm that you said even if the patient tested negative, you are still strongly recommending that the PPE should be worn, and that there should be no letting guard down.
Yes, we would not recommend that you let your guard down just because the test result is negative. If the procedure that you're performing requires an N95 mask, you should wear the N95 mask.
Okay. Well,
I think that's the question that's being asked.
yes, I believe so. So we have another question that's just came in. It's taking about 7 to 10 days for getting testing results. What is your recommendation for timing of testing, getting results, and providing care?
That's a very important question, and it's been a huge source of frustration throughout the pandemic trying to get testing done in an adequate time frame. 7 to 10 days is really not going to help you very much at all because the person that you've tested could be exposed again within that time frame. What we have said, with a nod to the knowledge that there is or there has been a delay in getting test results back, we've said that you should get the test within 7 days prior to the procedure, but we prefer that you get the test as close to the procedure as possible, really within a day or two, if at all possible. And so you'll have to find out what kind of turnaround time the facility that you're using for testing can provide for you. This is one of the reasons why I think it's going to be very attractive for some practices to use a test like the Cepheid Gene Expert, which gives you a reliable test result on the same day, or the Abbott ID Now, a little less sensitive, but you can get a test result on the same day.
Okay. Thank you so much, Dr. Gerling. We have another question. What should I do if staff refuse to wear N95? Will a signed waiver be good enough to release me from liabilities?
I'm going to turn that one over to Dr. Aronoff.
Let me get my lawyer
Good move.
on the phone.
Good move.
So,
yeah, where did you get your law degree, Deanna?
oh, well, you know, I'm a woman of many talents. Anyway, so I do think you could, I think that's setting yourself up for a lot of problems because it doesn't just affect that one person. And I'm not a lawyer, but I don't believe that would be adequate. And I think the point I was trying to make in my presentation is, I know the N95s are uncomfortable. The duck bills seem to be more comfortable if people have problems with it. But if you do have an exposure in your dental office, it is so much work. And if you have to quarantine people for 2 weeks, it's heartbreaking. And it's very difficult for the dentist, it's difficult for the staff, and all you have to do is wear that N95, get it fit tested. We're coming up with a list that we're not endorsing any of these people, but we'll have it available so you can get fit tested in many different areas and of Alameda County. And I just think the best thing to do is explain the science to your staff and why it's so important to keep them safe and keep you safe for a multitude of reasons.
Okay, well, thank you so much. Okay, so I have a question for Dr. Say. Do you know, or when do you expect a saliva test will be available?
So saliva tests are available now, whether or not they become point of care tests where you can, buy one and just like run one at home, or, not point of care, but like over the counter type. That probably will be a little bit longer, but there definitely are kits where you just kind of spit into a cup, send the specimen then to a laboratory for testing, and they'll process the saliva sample. So those are available, they're just not point of care tests. So if you got a certificate of waiver, there are no tests on the market currently, like an antigen test or one of the Abbott Now or Cepheid tests that you can set up in a CLIA waived facility and start running. And I also oh, sorry, go ahead.
Sorry. No, I'm sorry, go ahead, I'm sorry.
No, and I also just wanted to mention, I realized I didn't mention this earlier. I know that the antigen tests are very rapid and are very ideal in a clinic practice setting. However, the federal government has purchased a majority of those supplies, and so availability to other people to purchase at this time may be limited, and supplies may not be ready until early or mid next year.
Okay, so for a follow-up question to that, so what if, like, there's a saliva test and the patient does it at home, right? And then they send it in. So is the test result acceptable for dental providers to use prior to aerosol generating procedures? Or do we
Yeah.
still need to require them to get additional tests?
Right, no, so if it is a test that has been FDA EUA approved for COVID-19 testing, those should be acceptable results. And even though they are home collected, it has been validated by the company doing the testing that it is acceptable way of collecting the specimen. The main part is having a authorized test at the back end to ensure that the testing is completed accurately. So even though it's a home collected test, because it's being sent to an authorized laboratory that is allowed to run it, it shouldn't be a problem to accept those results. But it would be nice for you to see a printout or some form of report to make sure that that's actually happening. And I believe Dr. Gerling mentioned that in his part of the presentation.
I have a question for Dr. Shea, a follow-up question. Am I correct in my understanding? I know that the saliva tests that are available there are more and more coming online, but I believe that they are all PCR tests. Is that correct?
Yes, currently
they're all molecular tests.
Yeah, they're all molecular tests. I would have to look into exactly what type of, kind of NAT that they're using. But yes, they're all type of more molecular style tests. It's not an antigen or anything like that right now.
Okay. And do you know if they're approved for use in asymptomatic people?
Yeah, so I mean, technically, all of the tests that we have are for, like even all the PCR tests, they're technically recommended for symptomatic people. The intent wasn't really for asymptomatics, but because of how COVID was spreading and knowing that people who could be asymptomatic carriers needed to be screened, it opened up the door for a lot more testing of asymptomatic individuals.
Thanks.
Okay, so we have another question that came in. So what is the county definition as an outbreak for a facility? I hope the question is clear, because that's okay. So what is the county definition as an outbreak facility?
Yeah. I think I can answer that question. I believe I believe it is 3 employees and or patients. In your setting, because the patients are coming and going, they probably don't really count. So I think that in your setting, we would be talking about 3 employees who do not live together, but their epidemiological link is their workplace.
Okay.
That makes sense. So that, in other words, there's evidence that that spread is happening at the workplace, as opposed to individuals acquiring the disease elsewhere and just happening, to be in the same work setting.
Okay, well, thank you. For all the attendees, if you have any additional questions, could you please send in the questions or type in the chat box so that our panelists can answer the questions for you instead of raising hands? Could just please go ahead and type in the chat box. And to find the chat box, you can look at the bottom, the icon, and it has like a little square box. That's where you want to type in. Okay, so another question that just came in. Are you mandating testing for healthcare providers?
So Dr. Shea and Dr. Aronoff, feel free to chime in. My understanding is that we are not mandating testing for any healthcare providers, with the exception perhaps of those that are working in congregate living facilities. We're not mandating it. That doesn't mean that it's not a good idea. And so there are some facilities that will be doing routine screening testing of their healthcare providers. And I should mention that if you decide to do that, I think there's pretty good evidence that the antigen tests, that are lower sensitivity, might actually be appropriate to use for screening healthcare professionals that are working together in the same setting, if you use the test frequently enough, even though that each test has a lower sensitivity. If you use the test frequently enough, say once or twice a week, and everybody gets tested once or twice a week, you would expect that you would catch the most infectious people and exclude them from that practice setting early during the course of their disease. And that could be a reasonable strategy to consider.
Okay, so you mentioned that congregated residential facilities. So do you think that would be a good idea to mandate the COVID test for those residents prior to providing dental care to them?
That's an interesting question. Deanna, do you have some thoughts about
Yeah,
that?
I think it's a good idea. It's what's being done in the jails, for example. So, I mean, you're not going to catch everybody, but it's a good idea. And I also know in the hospitals, for example, their staffs are being tested fairly regularly also. I think it somewhat depends on what kind of a dental practice you have. You know, if you're doing intubations and things like that, I think that's a higher level. So I think there's some indications for testing in dental offices. We're not mandating anything, but I can see where there would be, someone could make a case for that.
Okay, well, thank you. So another question that came in, home test is acceptable, but point of service use of test is not okay. Is that correct? And if so, what is the rationale for this difference?
Hi, for that question in particular, I should clarify that the home tests are not tests that you do at home. It's a home collection, and it's usually monitored by a physician either through like a Zoom meeting or some type of clinician. And then after you collect it, you then send that specimen in for molecular testing, like a molecular NAT test, which we've indicated had a higher sensitivity than many of the point of care tests that are available, such as the antigen test. But I should say that there are some point of care tests that are like real-time PCR tests, like the Cepheid Gene Expert, which you can purchase for a CLIA-waived laboratory that does have very high sensitivity and have given pretty comparable results to other non-waived real-time PCR tests. So hopefully that explains the differentiation.
Okay, so I know that there's one, Dr. Chan, your hand is raised. Could you go ahead and type in your question, because I can't unmute you. So Dr. Chan, if you have a question, please go ahead and type in your chat box. And we have another question right now as we're waiting for Dr. Chan to type in his question. Is county mandating flu vaccination like other counties?
So I'll just comment on that briefly. The county doesn't mandate flu vaccination. We don't order people to get flu vaccinations. We do recommend that everyone get a flu vaccination if they don't have a contraindication. Everyone over the age of 6 months should get a flu shot, but we don't mandate it. Now that's different than your employer might mandate that you get it as a healthcare provider, and we would certainly strongly recommend that all healthcare providers have a flu vaccine. I think that might be answering the right question, but Dr. Aronoff, Dr. Shea, if you have other comments, please chime in.
The only comment I would add would be, we don't mandate it. I think it's a really good idea this year to get your flu vaccine.
Absolutely.
Because the symptoms of the flu and COVID-19 are very very similar. And we do have treatments for the flu. We really don't have great treatments for COVID-19. And the other thing is, I myself called my local pharmacy to try to get an appointment, and they're running out of flu vaccines already. They'll be getting more in, but people are out there getting them, and you might want to just make sure that you get going on that before the flu season hits.
Okay. At this time, I don't have any other questions that are coming in.
Okay.
So
It looks like there's one more question actually.
Oh, okay.
How do we prepare and differentiate between
yeah.
flu and COVID?
Oh,
And
okay.
yeah, the symptoms are going to look very, very similar. And so I think you would utilize the same precautions for either, just because it's not going to, you won't be able to differentiate on site. They would have to either do testing or some other method in order to distinguish. And Dr. Gerling and Dr. Aronoff might have some more information about that.
Well, I would just add that you can be co-infected with both flu and COVID at the same time.
Right.
And that has been very clearly documented in the medical literature. And so it's not necessarily either or, it could be both. So my thought is very much along the lines of what Dr. Shea just said. If you have a person in your practice, as a staff member or a patient who has flu-like symptoms, you really should exercise the precautions, the same precautions that you would do for COVID, at least, and try to prevent the spread of that disease within your practice. There are some multiplex platforms that I think are coming online where you can test for multiple different viral pathogens at the same time. I just heard about that yesterday. I haven't actually read about it yet, but I think there will come a time in the very near future when you can get one specimen and test for both flu and COVID at the same time.
Yes, there's definitely already assays out that will detect COVID, flu A, flu B, and RSV. So there's many multiplex assays coming out in preparation for flu season so that people can, with one swab, differentiate between whether it's flu or COVID or potential co-infection with both.
Okay, great. So again, I don't see any more questions. Thank you so much to all of our panelists. And I'm going to turn it over to Dr. Ravi at this time.
Thank you, everyone. So our slides and the recording will be made available on our website. Please do visit our website. We have some very valuable resources. And again, I thank you everyone for your participation, and especially to our speakers for sharing such valuable guidance during these difficult times. So with that, we will be ending our meeting. Thank you.
Yeah, come on, Bonnie, in.
Alright, so we go to
He's not helping.